Hello, my name is Alora Fryer. I'm a third-year medical student at the Florida State University College of Medicine, and today I will be discussing stiff person syndrome, or SPS. This is an autoimmune disease with an approximately 1 in a million prevalence. It typically presents in the patient's mid to late 30s as progressive weakness, muscle spasming, worsening rigidity, and muscular hypertrophy due to involuntary motor unit firing. While the rate of motor unit firing is normal, the antagonist muscles are not inhibited and thus will co-contract against the force. This will initially begin in the thoracolumbar muscles and spread from axial to limb musculature. Spasms may last from a few minutes to hours, and at times with enough force to fracture bone. Episodes can be exacerbated by stressful events, including cold weather and infection, as well as fatigue. While the pathogenesis has not been fully elucidated, one hypothesis is that antibodies against GAD, or glutamic acid decarboxylase, cause dysfunction of GABAergic inhibitory neuron circuits, causing continued firing of alpha motor neurons. All forms of SPS have a combination of high serum anti-GAD and involuntary firing of motor units. Known forms include classical SPS, focal SPS, jerking SPS, and progressive encephalomyelitis with rigidity and myoclonus. In addition to progressive weakness, muscular rigidity, and co-contractures, patients may also experience fatigue, anxiety, depression, task-specific phobias, heightened startled response, limited mobility, and falls. Our patient was a 46-year-old female physician with a strong personal history of autoimmune diseases, including antiphospholipid syndrome, systemic lupus erythematosus, dermatomyositis, mixed connective tissue disease, and Sjogren's syndrome, with additional history of Ehlers-Danlos syndrome and Raynaud's syndrome. She initially presented with spasming of the paralumbar and pelvic girdle muscles, followed by debilitating stiffness, insomnia, diaphoretic spells, and intractable occipital headaches without visual changes. Her neurological exam was otherwise normal. In tireless pursuit of diagnosis, our patient was eventually found to have autoantibodies against GAD in the serum and cerebrospinal fluid with titers of 75 nanomoles per liter. She would go on to try a variety of treatments including cyclophosphamide, tizanidine, and 8 months of corticosteroids. Her treatment has now evolved to currently receive rituximab, baclofen, IVIG, gabapentin, and diazepam. Though the pathogenesis of SPS is not entirely understood, it is known that all forms of SPS have an autoimmune basis and are strongly associated with other autoimmune diseases. Of note, GAD autoantibodies have been seen in up to 90% of newly diagnosed type 1 diabetics. Anti-GAD antibodies are also associated with neurological conditions like cerebellar ataxia, limbic encephalitis with myoclonus, temporal lobe epilepsy, and others. As of now, no consistent correlation between the level of GAD antibody titers and severity of disease has been found, and although GAD is the rate-limiting enzyme for the synthesis of GABA, neurologic examination in SPS is typically normal. Because GABA synthesis is limited, MRI will typically reveal a regional decrease in motor cortex GABA levels. SPS may at times be mistaken for neurodegenerative disorders, as well as extrapyramidal diseases such as dystonias and myelopathies. And of note, a small percentage of SPS may be attributed to paraneoplastic variants caused by conditions such as breast cancer or small cell lung cancer. Regarding treatment, SPS may be improved by sleep, but typically our patients will need something more. GABA-enhancing medications such as diazepam, vigabatrin, and baclofen are commonly used, as well as immunomodulating agents like steroids, plasmapheresis, and IVIG. More recently, anti-CD20 antibody therapies like rituximab have been used, and there's a possibility of surgical relief through myoneural or peripheral nerve blockade. Our depth of knowledge will continue to expand regarding SPS, and I hope that this was helpful in developing an initial understanding of this condition through my patient's case. Thank you for your time.